Dr. Levy, in challenging cases of MOGAD where patients are not responding to therapeutic approaches and are continuing to relapse, what are some of the strategies that doctors can try?
So I think when you have a patient who isn't responding the way that you expect, it's always good to have an open mind and go back to basic principles and make sure this patient has what you think they have. So going back to their initial presentations and examinations and scans and making sure that it is indeed consistent with MOGAD and their laboratory result is from an established laboratory, etc. I think once you have confirmed that there aren't any atypical any atypical features of their condition, then it depends a little bit on what type of treatment they've had. As we've talked about, patients often respond very well acutely to steroids and to slower weaning of steroids, but it's not an acceptable long-term solution in patients. So other options that have been considered for relapsing disease include maintenance intravenous immunoglobulin therapy or oral steroid-sparing agents like mycophenolate. Some studies have reported maintenance plasma exchange, and of course you have drugs that deplete the cells that produce the antibodies, such as rituximab. And studies have shown that all of these agents have an effect in reducing relapse rates compared to no treatment. But these treatments don't invariably work for all patients. So sometimes it is a matter of finding the right treatment or the right combination for a patient. In patients who are chronically relapsing despite escalation of therapy, other treatments with different modes of action have been used with some success. So there's some agents that target the IL-6 pathway and other immune pathway, like tocilizumab, that have been reported as being successful. And I think one of the very exciting things now is that there are a number of clinical trials for patients with relapsing MOGAD, which have different mechanisms of action that could be used or could be considered for patients who continue to relapse despite current standard of care.
The first thing that comes to my mind when I deal with a case that's intractable to treatment is the steroid withdrawal effect. A lot of people will go on steroids to treat the relapse and then start a medication as a preventive and come off of the steroids, and then a relapse occurs, and the tendency is to blame the preventive medication that was just started, whereas really you're sort of triggering a relapse by withdrawing the steroids maybe too quickly, or there's some people who are just so dependent on the steroids, it's hard to take them off. And my go-to has been intravenous immunoglobulin, as Darshi said. I believe Dr. Chen has a study out that says that with the higher dose, there's a response rate of about 80%, but these are biased observational studies, so they're not fixed scientific studies. And for people who, despite my best effort, I cannot get them to stop relapsing, there are these clinical trials, and I think that these are sometimes the best options for people who've tried everything, and hopefully some of these drugs will become approved later on.